Hello, I'm Benjamin Miss, and today we're talking about disorders. This is going to be from the neurological and functional brain side, and we're going to be looking at different types of disorders. Some of the questions we're asking are going to be the differences between things like psychiatric disorders, brain injury, and neurodegenerative diseases, how they're functioning in the brain. There's going to be neurotransmitters involved, ions, chemicals, and interestingly, we would be sure that there are certainly some brain involvement for each of these things, right? Psychiatric disorders are not purely behavioral diagnostically. We can see that there's other things going on. So we'll start with the psychiatric. And these are major depression, bipolar, anxiety disorders, which is a whole host of disorders, and schizophrenia. These are probably the best place to start looking at areas in the brain that are going to be involved. And with general anxiety disorder, we consider, with anxiety disorders, we consider generalized anxiety disorder, post-traumatic stress disorder, obsessive compulsive disorder, and panic disorder. And one of the things we see right here, right away, is there's different areas in the brain involved in each of these things with quite a bit of overlap. One of the areas we see quite frequently involved is the insula. The insula, if we recall, we can't see it on the surface of the brain. We have to go behind the temporal lobe. It's brain surface. It's basically like the surface area with the sulci and gyri, but it's somewhat hidden because of the way the brain is structured. Now, the insula is part of that, like, hey, surface area is great, and it's useful. So, but it's kind of not really discussed as much with the frontal, temporal, parietal, and occipital lobes, the four main lobes. But then when we look at brain surface area, we have to consider insula, right, which is that insular lobe behind the temporal, kind of under the parietal. When you can see it here, in a coronal cut. And we also consider the cingulate, which is right above the corpus callosum. So it's this extra area, the sulcus and gyrus, that aren't really considered to be part of the frontal, parietal, or occipital lobes, even though it's kind of in that area, like right next to where they are. So we're looking at these areas that are involved, and we clearly see that there are certain areas involved when it comes to anxiety disorders in terms of function. So you look at treatments for anxiety disorders, right? And one of the big ones is SSRIs. Okay, they are higher dose than for depression, and these are things like Prozac, Paxil, Zoloft, the classic SSRIs. And SSRIs are selective serotonin reuptake inhibitors. What this means is more serotonin is available in the synapse. We know that the brain adapts to these things. So these things are generally supposed to be short-term treatments, but tend to be given often longer term. We also consider benzodiazepines. Now, benzodiazepines are given often for extreme cases, right? So someone who has like extreme panic and is unable to function, sometimes they might be diagnosed with one of these drugs. These are things like Xanax and Valium. The problem is they're highly addictive. Now, these affect GABA. They basically improve the function and boost GABA, GABA being the brain's primary inhibitory neurotransmitter globally, so it slows them down and relaxes them. The problem is it's much more than just the panic, much more than the anxiety, global, and it can, make it hard to function. The classics are the tricyclics. These tended to affect more than just serotonin, right? They tended to affect more of the monoamines, but also have more side effects. So they're kind of, used after the SSRIs are tried usually. Neuroleptics are tranquilizers. And then you have therapy, right? And other things. So before we get into, let's start with therapy, right? Cognitive behavioral therapy is, looking at thoughts and behaviors and trying to basically help people to troubleshoot anxiety and deal with it. Now, we generally are aware that any kind of issues, and this will include the mood disorders, depression, therapy plus medication, right? So it's not like you're just doing one or the other. And the therapy is what's really going to lead to the long-term change, while the medication is temporary. Now, people can have short-term disorders, and this is very common for people to have periods of anxiety, periods of depression, have treatment, and then move on. But for most people, the therapy is really going to be the lasting effect. Now we get into the really invasive stuff. So deep brain stimulation can be used in cases of extreme, untreatable anxiety disorders. This involves putting electrodes directly into the brain. And it's kind of like, well, we think these areas are involved. We can stimulate, we can interrupt, we can do things to hopefully change the brain activity. The issue is it's extremely invasive and there can be severe side effects, like major differences in functioning, personality change. Another extremely invasive technique is lobotomy. And I know it sounds weird, like lobotomy, like the Walter Friedman stuff with the ice pick behind the eye and then just like wiggle it around is horrendous. It is, however, in extremely rare cases of untreatable, for instance, obsessive compulsive to the point of someone being unable to function, they could do partial lobotomies where they don't destroy the tissue, but they cut the connections. So they would cut some of the white matter tracks that connect to like the orbitofrontal cortex, where you see, for instance, involvement in that. Another anxiety disorder to consider is PTSD, and we can see what's actually happening in the brain. PTSD is post-traumatic stress disorder and is often associated with trauma, right? But not just trauma. Usually there's also underlying stress. So there's like a great deal, it's like a stressful environment. And this is why we see it commonly in like soldiers, right? Returning from war zones. The environment is already stressful. So they're on high alert. Your brain is pumping, your stress hormones, and you're like kind of primed. Then something extreme happens, explosions, injuries, deaths, assaults, attacks. It's not just soldiers. It can also be, assaults, sexual assaults, any kind of traumatic event can cause this immediate change. Now, research has shown that you can actually predict who's more likely at risk, like in terms of soldiers, who's more at risk due to how active the amygdala is, and then the hippocampus and prefrontal cortex size and activity. Also low neuropeptide Y. Now, what this tells us is that this connection between the amygdala and the hippocampus is extremely involved. Overactive amygdala, small hippocampus, you can have a single traumatic event lead to a rewiring. And I know we don't love the term rewiring, but basically like an extreme change in the connectivity between these things, so that non-traumatic things that may appear related to the event can cause people to re-experience the trauma. People experiencing PTSD will often have shallow sleep. They'll show more REM, increased cortisol and norepinephrine, and so you end up, with extreme, continued stress. So the body is continually under stress and continually kind of like reliving or reassociating the experiences related to the traumatic event. Now, for instance, beta blockers can be a treatment here, right? Because of, blocking the effect of norepinephrine. This can help people to kind of calm down and relax. In this case, you absolutely want to combine therapy with some kind of medical, medication treatment to help people deal with these things, right? Because you need to kind of really reprogram the behavior. So now we look at the mood disorders, and the two we'll see here are major depression and bipolar. What we see here with mood and things, right? Like unipolar is like depression, right? So here's kind of like your average. We see that kind of line across. That's like your average mood. And everybody goes up and down, and you see the green line. Yeah, people are happy, people are sad, right? The issue is taking these things to an extreme, and that's when people will often need treatment. We also see different types of bipolar. where you can have either hypomania or mania, and these things tend to last a particular length of time. Now, this also, we know that bipolar is more difficult to treat than depression because you're dealing with two things, right, rather than one. With a depressed person, you want to just bring their mood up, right? But with a bipolar person, you want to flatten the extremes. So looking at major depression, you look at the characteristics, right? Feeling sad and helpless every day for weeks, with the characteristics of little energy, lack of self-worth. Oftentimes you'll have suicidal ideation, hopelessness. Difficulty sleeping is interesting because people who are depressed often feel better in the evening than the morning, so they don't want to go to sleep, which means you kind of enter this insomnia pattern where they're staying up, but then having difficulty waking up in the morning. You kind of increased sleep, so often it's like an interrupted type sleep pattern rather than just insomnia or increased sleep. Concentration difficulty, and what's called anhedonia, which is little pleasure, not experiencing pleasure from things that typically would give someone pleasure. When we look at this disorder, we see that a big predictor is the absence of happiness rather than increased sadness. Oftentimes there's like a numbness, right, where they're just simply not experiencing joy, which can be extremely disheartening. When you look at the incidence, we know that childhood depression is equally likely, but after basically puberty, it's more common in women, extremely, like 70%. 7% of Americans have experienced at least one episode in the past year. That's 7 people out of 100. That means you've probably known somebody, like somebody close to you, who experienced at least one major depressive episode in the past year. That's how common this is. And episodes of depression are more common than long-term. Oftentimes, people experiencing an episode will not seek treatment because the episode might last for a few weeks or a few months. And by the time they realize that something is like severely wrong, they're kind of recovering from it. However, people who do have repeated episodes, it can be helpful to be aware of it so they can seek treatment earlier on. Now, when we look at how it works, there is a certain genetic component. People who have it in the family we do see that. Some genes associated with it are also associated with anxiety disorders. It's called comorbidity. Basically, comorbidity means you have two things at the same time. Just because you're depressed doesn't mean you can't have anxiety, right? Just because you have anxiety doesn't mean you can't be depressed. Substance abuse disorders are common, right? And oftentimes this is self-medication. People try to medicate, take care of this depression, and it can lead to addiction. You can also see relations between, eating disorders, migraines. These people also, like your PTSD people, we're talking about a small hippocampus and prefrontal cortex, right? And low activity in those areas. So again, there's these predictors, and that also shows us the relationship between disorders. You can have disruption of the hypothalamus, which leads to increased cortisol, right? We saw cortisol implicated somewhat in our anxiety disorders, like PTSD. Cortisol being our brain's body's primary stress hormone. And so again, it's this experience of stress where there isn't. You also see what we call disruption of the monoamine system. Remember, our monoamines are serotonin, norepinephrine, epinephrine, and dopamine being the primary ones. And so you see, they use the term, you may have heard the term chemical imbalance, right? There's a pop song recently where the singer's talking about, imbalanced, neurotransmitters, basically, right? Chemical imbalance, which is kind of an odd term because what is the balance supposed to be, right? And things do get out of whack, but saying chemical imbalance isn't really descriptive, right? Saying that, because here's the thing, in the same thing as anxiety disorders, there's brain area involvement that goes beyond the neurotransmitters, and it's only in certain areas. These things tend to be, for instance, the basal forebrain, right? The nucleus accumbens, we see less activity there in people here. And remember, that's the area down here, right? this area here. You call from development the tip of the neural tube. This is also where your dopamine system runs through. And so it's not just serotonin, it's also dopamine involved in pleasure, and low activity here associated with these things. Treatments include SSRIs, right? These are drugs, any drugs that raise norepinephrine and dopamine, like your tricyclics, right? So SSRIs are serotonin, but some of the newer treatments, right, are targeting other monoamines. So they might affect serotonin, norepinephrine, and dopamine. But again, these things tend to be global, which can be, again, going outside of what's the need. Really, you might want to only target certain brain areas, and future treatments might be better at doing that. You also have CBT, which is to change thought patterns and thinking, right? Again, CBT, cognitive behavioral therapy, extremely important. Even in depression that seems to be non-environmental, a lot of depressions are environmental, which means relationship, family, those kinds of things, jobs, stress, these things can affect us. But even in those cases, it can help people. And then you have TMS. One of my favorite new treatments is transcranial magnetic stimulation. This is the magnet, basically the very powerful electromagnet they put over an area of your brain. Actually, this area here, they put it over the frontotemporal parietal, this kind of area here on the left side, in order to increase the activity in that area. They can actually enhance it, and people will often, it's that kind of like feedback where you don't, if someone's depressed, doesn't do things and then feels more depressed because they're not doing things. If you can enhance that kind of go in that way, that kind of like go system, right, the approach system, someone can be more active, and that can have a very positive feedback on their mood because, hey, they're getting things done now, they're being active now, their body's moving, they can exercise again, they can have like a very powerful effect, feedback. An extreme one is ECT, electroconvulsive therapy. This is done, we see this in cases usually that aren't treatable in other ways. It is often temporary, but it can have an immediate temporary effect where within hours of having the treatment, somebody can wake up and feel less depressed. Now, ECT got a really bad reputation because of a movie called One Flew Over the Cuckoo's Nest, based on the book by Kesey. And the patient is basically abused with electroshock therapy until he's, they are, in order to kind of control them very, very negatively, right, used abusively. Modern ECT, and it's dramatized with like the bolt, the bite thing in the mouth, and they're shaking and having these extreme seizures. Electroconvulsive is, convulsive is seizure, but modern people are medicated, sedated. The electrical charge is fairly minor, comparably, and it's mildly disruptive. The biggest issue, the biggest side effect appears to be memory, right? There tends to be some amnesia associated with it. And really that's the biggest concern. That's why it's like kind of like a let's hold off on this. The other one is, what are you really doing? It's like kind of like you're turning the brain off and then turning it back on again, which, works for all sorts of things, turn it off and turn it on. Most students find that after they sent like a bunch of emails trying to figure out why it's not working, they just restart it and all of a sudden, Now this can work for people, but again, it's kind of vague on what's happening, and that's, I think, people's biggest concern about it, right? Like what's actually going on. DBS is deep brain stimulation, mentioned with anxiety, but it's extremely invasive, putting electrodes directly into the brain, and trying different things to increase or decrease activity in those areas, right? And here we simply see a synapse, getting us an idea of an SSRI. For instance, SSRI means selective serotonin reuptake inhibitor, which means your serotonin might get dumped out here into the synapse and then is retaken up into the presynaptic neuron. The issue is you block the reuptake, and so more serotonin is available. But like any other chemical, the brain adapts. Now, bipolar has the periods of depression we talked about, but also mania. Mania involves energy, racing thoughts, insomnia, risky behaviors, sex, drugs, gambling, spending, It's not always like feeling good. Mania can just be like a lot of energy that's undirected, and hypomania is kind of like a lower level of that. It may lead to, over time, some could have like this kind of like low level, and then like increases into bipolar, or people can just have periods of hypomania, right? So we look at what's happening, and this involves the frontolimbic network, including the hippocampus, amygdala, and the striatum, right, part of the basal ganglia, part of the dopamine system. It's difficult to treat because the drugs that treat, you can give an SSRI for the depression part, but that can increase the mania part. You give certain things like lithium. Lithium is a really interesting ion. They're not really sure why it works. I think in some ways it might simply displace other ions, right? And because it doesn't have a direct ionic effect, like, I'm totally spitballing here, but like, calcium and sodium and potassium. And if it's displacing these other positive ions, it could just simply reduce neural activity overall. It's shown to have neuroprotective effects on the cingulate cortex, the superior temporal gyrus, the hippocampus, and it downregulates dopamine and glutamate receptors and upregulates GABA receptors and may boost brain-derived neurotropic. So you end up with these different, ways that it works, and this can help overall, right? Downregulating dopamine and glutamate, kind of a go, upregulating the kind of calm, and it seems to have an effect. Other anti-epileptics include so you end up with these other drugs given for seizures, and lithium's also given for seizures. So there seems to be some relation between that. So these neurotropic factors are found in the brain, are protective, and so they're generally kind of helpful in that way. Now the next one is schizophrenia. This I think is a lot harder to describe and understand, because schizophrenia is a disorder of cognition. It goes beyond mood into thinking, including things like losing contact with reality, hallucinations, right, and delusions. These are the positive symptoms, and negative symptoms are anhedonia and low motivation. And it's kind of a terminology thing. Positive isn't good. People are not like, oh, yay, I'm having hallucinations and delusions. No, that's a break from reality. And the negative being, maybe lack of energy, anhedonia, lack of feeling pleasure. Generally appears between 15 and 25 during prefrontal cortex maturation. Often we'll see 20 to 30. And oftentimes younger people may have some like kind of symptoms that appear schizophrenic but don't necessarily develop into schizophrenia. So it's odd behavior during puberty isn't always predictive. Well, genetic predictors are really interesting because there appear to be different types of schizophrenia, and recent research suggests that schizophrenia is like a cluster of diseases of the brain rather than a single one, right? And they all have their own genetic precursors. Some of them extremely predictive of schizophrenia, some not so much, and it requires basically both environment and the gene, right? In almost every case. In some cases, the genetic predisposition is basically you're going to have schizophrenia. In others, it's a predictor, but also you need like environmental stress. And so these clusters may lead to better treatments in the future, because just because someone's diagnosed with schizophrenia, it's more important to look at the individual symptoms and treat symptomatically, right? And say, okay, we know that for this group of symptoms, this treatment works, right? But not this treatment. Well, there's an interesting aside, and this has been debated, but it seems pretty clear that nobody born blind, and this is cortical blindness, basically occipital lobe blindness, has developed schizophrenia. So what this has to do suggests there's something in this network associated with the development of schizophrenia, right? Lateral geniculate nucleus in the thalamus, occipital lobe, something's happening here in regards to it. treatments, old treatments, like the first treatment for schizophrenia was Thorazine. It's called an antipsychotic. Basically blocks dopamine receptors, and so you end up with fewer of these positive symptoms. The biggest problem with these things are, we like dopamine. Dopamine feels good. So if you block dopamine receptors, how likely are people to do their treatment? Or are they more likely to say no, right? A lot of homeless people are severely mentally ill. Many of them do have conditions like schizophrenia, which are extremely difficult to treat. And you can end up with, this break from reality, which makes it very difficult to function. And it's really a lot of work needs to be done. The newer drugs also suppress serotonin. So we see newer drugs tend to do less to just like globally block dopamine. So that can be helpful. They can block both positive and negative symptoms. But having people maintain treatment, again, is really hard because often the drugs can lead to anhedonia and other side effects. I mean, you have tardive dyskinesia, which is a side effect of Thorazine, which is, kind of tics, like movements, like they develop, uncontrolled movements. A newer one is that nicotine appears to relieve symptoms. And so research is being done on this. Now, nicotine, we recall, is part of the acetylcholine system, or I should not isn't part of it, but affects the acetylcholine system, suggesting that there is, using something related to this could have some effects on schizophrenia. All right, now we look at brain damage and autoimmune. And for instance, here we see things, like strokes and tumors, and also something like neurological autoimmune deficiency syndrome. This is neuro-AIDS, basically the effect of long-term infection, and then multiple sclerosis, which is an autoimmune disorder that doesn't have a viral cause, but is more of a can be genetic. So, brain tumors. There's different types of brain tumors, and you may have heard of them. Not all brain tumors are equal. Some brain tumors are extremely slow-moving. Some are extremely aggressive. Some, and you can see what they are. Gliomas are from glial cells, and then you have different types of those, like glioblastomas are immature glial cells that basically develop into tumors. Astrocytomas are astrocyte-based. And these tumors are caused by cancers, right, are caused by uncontrolled growth. That's why the treatments for cancers are things like drugs that stop cell division. That's why the side effects of a lot of cancer treatments, like the chemotherapies, tend to be things like nausea, hair loss, because these are parts of the mouth lesions. These are parts of the body that are constantly kind of like replacing, constantly making new cells. So if you block them, if you basically start attacking and stopping cells from dividing, you're treating the cancer, but you're also affecting the body. Newer treatments tend to be more targeted, but the effects of tumors is related directly to where they are rather than what they are. And when you look at things like meningiomas, that's another one. That's not in the brain. That's those are the layer surface of the brain, your meninges, right? Your pia mater, arachnoid, and then your dura, right? So these are the parts that are kind of like around the brain, and these things may grow there and put pressure on the brain, but not actually damaging the brain itself. And generally easier to treat because they're not directly inside the brain, although these things can do that. So we look at slow-moving brain tumors that are benign may not be treated, right? They might say by the time this is a problem, you're gonna die of something else, or we'll watch and make sure there's no major damage or personality change. Sometimes if the tumor is accessible, they'll do surgery, and accessible means close to the surface, easy to get to, not in like in your, for instance, deep in the brain might be really hard to get to. near your language centers or a major important, cognition center, they might leave it alone because the surgery could have side effects that are worse than the tumor. Chemotherapy can't cross the blood-brain barrier generally because the blood-brain barrier protects exactly against, chemicals like this. So one of the things they have to do is they can implant it in the tumor. If they do surgery, they might actually remove as much of the tumor as they can and then implant chemotherapy, like kind of like a slow release chemotherapy, wafers or something that'll dissolve and release the chemotherapy into the area. Radiation, but again, these treatments can have major side effects because again, this is extremely, chemotherapy is toxic to the brain, radiation is toxic to the brain. Even when you're triangulating, you're sending like points of radiation from different areas to target, so radiation is coming from here, from here, from here, from here, from here. And so it's like all here, but it's also, not good for the rest of the brain. Newer treatments include ultrasound, which seem to have less toxic effects, a very, fine beam of high frequency sound waves that can show promise breaking up tumors. But this is the issue with cancer in general, right? Cancer is not just one thing. It's out of controlled cell growth, and treating it can be difficult because each type can have different issues. Now, cancer and tumors are a type of brain injury, but when we talk about brain injury, we're generally thinking of like a TBI, a traumatic brain injury. So somebody hits their head and it causes damage, right? A gunshot wound to the head, right, would be a traumatic brain injury. A car accident where they slam their head would be a closed head injury where the skull doesn't break versus an open head injury where the skull does. And often closed head injuries can be worse because the brain is kind of like rattling, it's banging. It's coup counter coup injury, which is it hits, then bounces back to the back and then hits the front and the surface where all that nice stuff is. You end up with bruising, which is, blood leaking. And that's toxic to brain cells. And things like concussions are bruises to the brain in most cases, which are bleeding, which is really bad. Like concussions are like, oh, it's just a concussion. It's a brain injury, and that's why you see like, really a lot of movement to add protections, especially for developing brains, children's sports. Boxers, for instance, are just putting their brains into risk of concussion, quite severely. Brain injury can lead to behavioral changes. And I've worked with brain injured patients, and oftentimes you can predict the type of behavioral issues due to where the injury is. But for closed head injuries, you really often see global type issues. And one of the big ones is frontal lobe issues, frontal lobe syndromes where you have like lack of inhibition, maybe some difficulty maintaining attention, maintaining a schedule. Other things like the neurological AIDS complications, right? HIV-associated neurocognitive diseases have been shown. Now that AIDS is really, or HIV even, is kind of treatable to a certain extent, people aren't going to die from it necessarily, and they can live a typical lifespan in many cases. But you see over half of people with HIV do end up with some kind of neurological disease because nerve damage can happen both from the disease itself and from the drugs used to treat it. So again, this is something like AIDS dementia, which might be an earlier onset of dementia, but you can see abnormal white matter, loss of nerve cells, and peripheral neuropathy. So the disease itself can be attacking the nerve cells, attacking the myelination, and causing these long-term effects. And then the last one of these is multiple sclerosis. Multiple sclerosis, right, being kind of a, we think of like a damage and autoimmune disorder. This is an autoimmune disorder. It's inflammation. It's an attack with probably has genetic link. And can damage the nerve cells, attacks the myelin, right? And this can cause damage. So myelin, they are those nice big white matter tracts, right? You think about here's an example. Here's your optic chiasm, right? Your vision is coming along these really nice, thick optic nerves that are coming from the back of your eyes, sending this, visual information. Well, MS is going to be attacking your myelination. This can disrupt vision. This can disrupt movement, right? Because your nerves are being attacked. Newer medications can partially control it. It's not totally treated. And there's a really interesting link that it's less likely to have in tropical. I think it's about twice as likely in temperate versus tropical climates. So the colder it is, the more likely people are to develop MS. Now, the last section of diseases are neurodegeneratives. And this, I've mentioned before, and as we kind of summarize what we're doing in physiological psychology, we're seeing really the value of studying this. These are all things that are ongoing, that need treatment. Brain injury, psychiatric disorders that are linked to brain function, and our neurodegeneration. With an aging population, we're seeing increasing rates of Alzheimer's. And the study of these things, the treatment of these things is like the holy grail. It's the, change the world, change people's lives. You can keep the body healthy as long as you want. You can do all the, cosmetic, plastic surgery, but the brain is going to continue to age. And so treating these things is important. We look at Alzheimer's, which is a fatal degenerative dementia, and we consider that as we age, it becomes more likely. Over 65, a small percentage of the population has it. By the time you hit 85, half of the population is diagnosed with Alzheimer's disease, and it's associated with what we call amyloid plaques. So here is some gray matter in the brain, and we see these dark spots being these buildup of these plaques. Early is increased memory issues. People might forget things. Mild Alzheimer's is where you start to see personality and behavior changes. Moderate, they might have trouble recognizing family or learning things. And by the time it's severe, there's no functioning without help. The earlier it hits, the worse it is. The younger someone is when they have it, the more severe. We look here, there's some other things that are related. Lewy body disease, which is related to a buildup of certain proteins that are typical. We see in the image here the severe death, right? We're just seeing massive cell death. And this is related to the buildup of beta and tau, right? And these are two, misshapen proteins called prions. Other things that are similar to Alzheimer's, but not the same etiology, are frontotemporal dementia, stroke, and vascular dementia, right? So vascular dementia is a common and tough to diagnose. Basically, poor cardiovascular health leads to things like blockages. Blockages create mini strokes that can build up over time that will lead to major brain damage and dementia. Now we look at these proteins. Amyloid is believed to be the primary cause. In this image here, the brown is the amyloid and the blue are the tangles. And the tangles are building up in the neurons themselves, right? Damaging the neurons themselves. And the tangles are building up outside, getting in the way of synapses, getting in the way of function. It's first seen in the cortex and spreads from there. And the tau is first appearing in the hippocampus. So you see, behavioral and memory changes happening along these lines. Now, both of these are typical proteins or related typical proteins that kind of go bad, right? Get toxic. And, we might have these things happen even in a younger brain, but our brains are decent at kind of getting rid of these things. And as we age, it gets harder and harder to get rid of these things building up. It's believed that obesity may increase rates, which is not good for Americans, especially being that our obesity rates are ridiculous. Inflammation may increase rates, and inflammation can be related to diet, right? Inflammatory versus anti-inflammatory foods. Plant-based diets are often seen as healthier. The earlier it's diagnosed, the earlier a person has it, usually the worse it is. It has much stronger genetic cause for early Alzheimer's. Some drugs can relieve cholinesterase inhibitors. So basically drugs that block the breakdown of acetylcholine can help improve learning and memory. So you want more acetylcholine, seems to be helpful. And then the NMDA receptor, which is part of the glutamate system. We're talking about, This allows calcium to enter the cell, and calcium is toxic to Alzheimer's, so blocking it, or toxic in Alzheimer's, builds up in this way, so blocking it can help. But there isn't any treatment, and you'll see these like kind of big, press releases like, oh, treatment, cure, and it's not. And part of that is understanding that it's a prion, these misshapen proteins. These are extremely hard to treat. Parkinson's. It does increase also in likelihood with age. The older people are, the more likely they are to have it. Early symptoms include motor problems like slow movement, rigidity, and tremors. Tremors is generally considered to be kind of like the major thing, like that kind of shaking, right? Like this is the major symptom. But really, one of the biggest things you see is this inability to initiate, right? This lack of initiation, this extreme inhibition. At later stages, you see cognitive decline. You end up losing dopamine cells in the substantia nigra. And also, you have these Lewy bodies that are present. There's also Lewy body disease, which can be related and appear like it. But the Lewy bodies are a protein involved in dopamine transport. But Lewy bodies, when you end up with like these kind of like buildup, these things get tangled with their proteins and start to cause these same kind of problems you see with the plaques and tangles of Alzheimer's. Now, treatment is traditionally done with L-DOPA. It's a dopamine precursor that can cross the blood-brain barrier. Dopamine cannot, so you can't just give people dopamine. But it can lead to dyskinesia on its own, basically, uncontrolled movements, involuntary movements. And the issue is you can also see psychosis involved sometimes because you're basically boosting someone's dopamine, and boosting dopamine can have also these effects. It's kind of like Parkinson's is this lowering of dopamine over time, right? With the death of the substantia nigra cells, but it's not like steady. It's like up and down. So boosting with L-DOPA, you can get kind of like extremes of dopamine production. Better to treat, but you can see the side effects here. They've tried things like increasing the amount of dopamine. They've tried stem cells, like injecting stem cells into the deep brain, substantia nigra, basal ganglia. The problem is they're undifferentiated. It's kind of like you can't grow an organ outside of a system that's developing because it doesn't know what to do. Stem cells are going to become things, but you can end up with dyskinesias, right? Rather than treating the Parkinson's, now someone's got Parkinson's and dyskinesias, which are these uncontrolled movements, because these new cells, they don't know what to do. They don't know what their job is. Deep brain stimulation. Originally, this is where we see it more so than in the psychiatric treatments. Deep brain stimulation has been used with Parkinson's for a long time, and when successful, can have an extremely positive effect on a person's function, right? They can function much better because it helps to regulate. Instead of having this kind of like jittery decline, you get a slow decline, right, of your dopamine, but you're still getting a much more consistent production, and it's easier to function. And then boosting things like L-DOPA can have an effect without necessarily the side effects. Can reduce tremor, increase the ability to function, extend quality of life. Cigarettes and coffee. Well, this is interesting. People who smoke and drink coffee seem to be less likely to develop Parkinson's, and it actually appears that it's not that it actually is causal. But again, we're looking at the acetylcholine systems, the dopamine systems. So it seems like there's really some interesting effects here in regards to, I'm not saying go start smoking cigarettes. A lot of research says coffee is good for us, but coffee is awesome. So anything that says it's good for us, it's like chocolate and alcohol. Any research that says drink more wine, I'm like, really? Like who's doing this research? Are the researchers just kind of sitting there like pounding some bottles of red, while they're thinking about how important it is, same kind of thing. But it does seem that, again, if you're affecting the acetylcholine and dopamine systems with these drugs, really, I mean, the number one abused or used drug, is in the United States is caffeine. It's massively used. Um, and anybody who drinks, caffeine will tell you, for most people, yeah, sure, you get energy, but then if you don't have it, you get headaches, you get bigger ups and downs. So there's some interesting possibilities here, but nothing really helpful. Huntington's is the next one here. This is has genetic dominant inheritance disease. Basically, if you have a parent who has Huntington's, you have a 50% chance of getting that gene. There's also mutations that happen, so you can just develop it naturally, but it's rare. And the more of these it's a 6' protein, and the more of these copies you have, the more likely it is to clump and the more likely to have damage. So basically, the extent of the genetic mutation will actually predict the severity of the disease, how fast it progresses. Early symptoms include irritability, mood swings, depression, and what we call chorea. In fact, the disease has also been called Huntington's chorea, and the chorea refers to small uncontrolled movements or tics, like the person is continuing to twitch. There are some new therapies under development because Huntington's has been seen very much as a death sentence, and so anything that can block the progression would be a miracle to people. The people doing this kind of research are performing, modern day miracles, making the lame walk again, that kind of incredible work. Doing neuroscience research is absolutely incredible. The last one here is ALS. And ALS is also called Lou Gehrig's disease. Lou Gehrig was a baseball player who was, strong and fit, was diagnosed with this disease and was dead within a few years. It starts with muscle weakness to eventual paralysis, and it's 3 to 5 years from diagnosis to death. It's called Lou Gehrig's disease oftentimes because he was the most well-known person who had it. To most of you, you're more familiar with someone named Stephen Hawking. But Stephen Hawking's case was extremely atypical. Most people aren't even aware of what he had because Stephen Hawking had an extremely early onset case of ALS that progressed incredibly slowly. He lived nearly a typical life, really a typical lifespan. I think he was in his 70s when he died. And he was diagnosed in his 20s or 30s. So that was really, really interesting, and was able to function, with a lot of medical intervention. But that was really quite interesting in that case. Now, there are some drugs that may stop the progression by reducing free radicals and decreasing glutamate. And so there are some promising treatments for severely increasing the lifespan of people who have been diagnosed with ALS, which again is good news. And I hope that as we reach the end of our, discussions of neuroscience, the brain, and here looking at disorders and treatments and the work being done, that you understand the value of what we're doing here. Understanding the brain, understanding how it works is a huge component of who we are, right? And how we function. And looking at the very possibilities of our future and what we can do to help people, to treat diseases. It's a wonderful thing and a valuable thing, and I've really enjoyed these discussions. I wish you the best, and I hope that you've learned a lot in our studies of neuroscience. Thank you.